Good morning, everyone. Thanks so much for coming today to the second day of our Immunization Economics Pre-Congress session. We have a really exciting agenda for today, and so let's get started. Can we have the clicker work, please? There we are. So I just wanted to start off with a quick recap of yesterday. So yesterday we started off with an overview session during which Logan Brenzel presented on the history of the community of practice. And then we had presentations from Anne Levin and Wynne Morgan on costing tools and vaccine introduction projections. We then moved on to an interesting session about COVID vaccine delivery costs, bottom-up and global modeled estimates with Flavia, Ronka, Annika, and Corinne. After that, we learned about traditional vaccine financing from Brendan. We learned about budget execution challenges in Ghana from Emmanuel, and Grace presented remotely on some new interesting activities from MRITE. And then we joined interesting breakout sessions right after lunch on priority setting and the full value of vaccine assessments with Philip, JP, Allison, and Raymond. And during the last session, we had a really great discussion with a panel including Logan, Raymond, Ula, Sarah, and Todi on some more strategic questions for our community of practice. And then last, we handed out the award, the handbook, to the winning poster, which was from Noemi on public financial management rules and procedures on vaccine financing in Sierra Leone. And so today we have a couple more interesting sessions. So we'll start off with Damien Walker from MSH. He'll present on the global survey. And then we'll get to a panel discussion organized by CHAI with several countries discussing transition challenges and how CHAI has been supporting them to in their immunization financing. And then after that, we'll have a session organized by Sarah Pallas together with Rupa and Sachi and Rachel on costing immunization system improvements, and after that, a discussion on cost of illness modeling challenges. For the breakout sessions, we'll have PATH organizing a panel to discuss methods in HPV costing and malaria costing challenges. And upstairs, we'll have a session on HTAs for COVID vaccination in Nigeria, organized by the University of Nigeria, Benjamin and Chinyere, and Sergio from the London School. And after that, we'll have our lunch break, and then we'll have a really packed and really interesting session on how we're going to tackle this issue of developing cost evidence to reach zero-dose children, with Sarah Tuffer from UNICEF, Carol Kambia from IDRC Kampala. Louise will present from Village Reach on drone delivery of vaccines, and then we'll have a panel discussion with Ayoma, Stephen, and Ula to discuss the future for this body of work. Then we'll have another coffee break, and our final session be on fostering use of evidence with Kaja Abbas from the VIMC, Uni from WHO will be presenting. We'll have Todi and Raymond giving presentations as well. So just a few housekeeping reminders for today. So once again, if you haven't registered with any of us, please come find any of us and we'll check you off from the list. If you haven't used your lunch voucher from yesterday or you're not planning to use the one from today, please give them back to us because we'll get reimbursed for those. If you don't have a lunch voucher yet for today, also ask any of us and we'll give them to you. And if you didn't get a chance to see the posters yesterday, please go find them. They're still upstairs in the Frisia room. And then a word from our communications colleagues. So if you want to Twitter about this session, please go ahead. Here are some of the tags that you can use, the general conference hashtag, but also our own immunization economics tags. I can't tell you how it works. I don't have Twitter myself, but so here are the instructions on that. And so without further ado, let's move on to our first session, introducing Damien Walker to present on the global survey.
Thanks very much, Laura. And Laura, did you walk away with the clicker? I think you did. All right, thank you. So, good morning, everyone. Sorry I couldn't be with you yesterday. I flew in yesterday evening and had a few challenges getting here. My flight from DC to New York was cancelled, so I jumped on the train to get to New York and then obviously caught my flight to get here. So very happy to be here. I'm sorry I missed all those interesting sessions that were just introduced just now, and a quick overview. So I'm going to be presenting some findings from a third global survey that we've done at MSH. I'm presenting these findings on behalf of my colleague Ishani, who unfortunately couldn't be here. She had to make a last-minute trip to Ghana, but she's been leading this work for us at MSH. My colleague Annika, who presented yesterday on some of the work in Malawi, also is part of this work. Chris Yohalim is an active member of this special interest group, and myself, Damien Walker. I'm a senior technical director at MSH and lead our practice area in health economics and financing. So in terms of what we've been doing, this is actually the third of 3 global surveys that MSH has done. And the first one was conducted in November of 2021. And we timed that in order to understand what was happening as countries were beginning to roll out the vaccine. And the main purpose of that survey at the time was to generate quick insights that could pressure test some of the data and assumptions that were being fed into the global costing. We repeated that survey in May of 2022, and then a year later, May of this year, we conducted our third survey. And as you can see on the right-hand side here, these are the 17 countries that were captured in this third survey. Important to note that the actual countries in each of the surveys did differ. The only countries that overlapped in survey 1, 2, and 3 were Malawi, Cote d'Ivoire, and Tanzania. This third survey, given the status of the pandemic, really focused on issues around integration, any ongoing efforts to prioritize high-risk groups. And this gives you a bit more of a flavor about the particular themes and topics that we focused on. As I say, in the first survey done about 18 months ago, really, we were trying to understand issues around whether or not new human resources were being hired, what were the predominant delivery modalities. You can see the topics in survey 3 that I'm going to present now are quite different. So really now with a focus on integration in particular, any innovations and the extent to which those innovations had been introduced and maintained. And then finally, a word on some of the specific subpopulations and the extent to which they continue to be prioritized or otherwise. So in terms of the respondent profiles, so we identified people within 17 offices that MSH or UNICEF had. We received 22 responses. So you might be wondering, well, where did those additional responses come from? They came from Tanzania and Pakistan. And the interesting thing there is that we had the opportunity to kind of validate some of the findings we got, unlike in the other 15 countries where we just had a single response. The good news in Tanzania and Pakistan is that those multiple responses all pointed in the same direction. So that did give us some peace of mind in terms of the findings that we were generating. In terms of who the respondents were, we were targeting technical directors, chiefs of party, and immunization experts in the offices. And you can see here the extent to which people were involved in the different parts of the COVID vaccine rollout. So I feel like I'm moving between the 2 different screens. So you're following me as I walk across the 2 screens. So here's a word in terms of the efforts towards integration as well. And I think there were some interesting findings here in the sense that a third of the countries had not met their vaccination goals. And this is not the 70% global target, but the national targets that had since been established. And those countries, even though they had not met their vaccination goals, had declared that COVID is no longer a priority in their country. It's also important to note that 3/4 of the countries said that COVID-19, even if they, of course, had met their targets now, is no longer considered a global health priority as well, or a national health priority. Most of the countries were now moving, therefore, towards integration. They'd moved on from an emergency response model to more of a routine model to continue the rollout of the vaccine. And that integration could be seen through existing PHC platforms, for example, fixed site health facilities in about 90% of the countries, hospitals, a similar number of countries identified hospitals as one of the main points of vaccination, and also community level health sites as well. Importantly, and I'll come back to this point in a moment with particular countries as examples, but over 70% of the countries indicated that mass sites are still being used nevertheless. Although I think there's probably issues, and perhaps this was raised yesterday with some of the costing studies, that the throughput at those mass sites is now quite low. So the differences in integration, I think it's quite useful to focus on a low-performing country, in this case, Malawi. If you remember the graph that I showed you with the different vaccination curves, Malawi was at the bottom. Today, it's still only achieved about 20% coverage of the population with at least 2 doses of the vaccine. On the other hand, you see Vietnam, which really outperformed many countries at over 90% of its population being fully vaccinated. And you can see differences, therefore, in terms of how they are approaching integration and the different delivery platforms that they are still prioritizing or otherwise. So when it comes to Malawi, ostensibly, the country is still prioritizing COVID-19 vaccination. Important to recognize that they have some significant headwinds with respect to vaccine hesitancy, and that is proving challenging to really move that needle on 20%. They had stated in the responses that they were still prioritizing COVID-19, and a piece of evidence to support that is the fact that they are still hiring human resources to get the job done. However, when you look at the total amount of money being spent on COVID, they did report that it was less than the previous year. This is an example of a country that is continuing to use mass sites as well, and campaigns as a delivery model. However, as I say, it's unclear the amount of throughput that these sites are seeing. In terms of Vietnam, not surprisingly, having achieved 90% plus coverage, they're not prioritizing COVID-19 vaccination, or they're not hiring anymore people specifically to get the job done. They also accordingly have reduced their expenditure on COVID-19, and therefore they're not using sites and campaigns anymore. The work they're doing to mop up any remaining people who are unvaccinated is much more focused and need-based. So the innovations, we saw some good news and some less good news perhaps. Over 80% of the countries have reported a lasting increase in cold chain technology. As a result of the pandemic, we saw a significant uptick in the number of countries that were reporting the use of new digital tools. And I think we've heard mixed things about this. On the one hand, that's quite exciting. On the other hand, we've heard from countries that it was a little bit overwhelming, a little bit ad hoc. And the last point is the fact that many of these digital innovations have not stuck. There wasn't a path towards sustainability. And perhaps it was never intended, but it's just worth noting that they have now begun to not use many of these digital innovations that were introduced. In terms of ongoing vaccination of priority populations, you can see here on the right-hand side that of all the different priority populations that were identified, not surprisingly at the top is the elderly population as well. That continues to be a group that is identified and focused in terms of any efforts to reach them. You can see that the different types of approaches, platforms, do vary by countries. We've already said in Malawi's case, they're continuing to use mass campaigns, but also door-to-door campaigns as well. In particular, in Ukraine, you can see that mobile teams are being used and perhaps a specific response to the challenges that they're facing with the ongoing war. In terms of challenges, some of these are also very context specific. So again, taking the example of Ukraine, unsurprisingly, there are challenges in terms of access to vaccination points. Finally, the bottom point there, it's notable that a number of countries that have performed quite well, they have coverage rates of 60, 70% plus. Examples there are Nicaragua, Belize, and Mongolia. They've stopped targeting specific subpopulations and have really chosen to integrate ongoing efforts more generally. So my final slide, just a few high-level key takeaways. Unsurprisingly, at this point, we've termed this global survey the post-pandemic survey. I think the evidence from the survey that we generated supports that point. countries have really moved on from an emergency response, as I said before, to trying to integrate ongoing COVID-19 vaccination into existing primary healthcare platforms and ongoing routine immunization. We did see an uptick in the use of digital innovations, but that hasn't been sustained. And as I say, I think that's a bit of a mixed message in many respects. Some of those were perhaps made specifically for the emergency response and weren't intended to be sustained, but we certainly have seen a decay in the use of those innovations. And finally, a point to summarize on priority populations. Those priority populations have not really changed drastically since the beginning, since the first survey that we conducted, but we are now seeing that the efforts to reach them are not being specifically targeted in all cases to reach them. They're being targeted more generally through integration efforts. And that is my final slide. So thank you very much.
Thanks. So we'll now take a couple of questions for Damien before we move on to the next presentation.
Hi, thank you so much, David, for that comprehensive presentation that you provided. I just wanted to find out from the survey, you mentioned that a lot of countries are still using delivery methods, using pandemic delivery methods as part of their integration. Did the survey look at how they're planning to sustain? Because I think now the finances are now moving back into traditional health programs. Did the survey look at that? How are they planning to finance it?
I'm afraid not. The short answer is it did not look at that. And I think that is something that we could always follow up with the specific responses from particular countries that indicated they were still using those platforms. We could certainly ask that question and try and dig in a bit further.
It'll be interesting to know.
For sure.
Other questions over there in the back?
Hi, morning. Thank you so much for your presentation. Very insightful. I'm Mariam from NextLeaf Analytics, based in Tanzania. I just wanted to sort of get your thoughts around what we've learned as you presented sort of regarding innovations and all sort of the global support that was there around equipment, for example, equipment around alter cold chain to support the countries during this time, and sort of now most, like you said, digital innovations are dying out, equipments are sitting there in equipment graveyard. So I just wanted to sort of get your thoughts on what we've learned about this as, you know, we're moving forward and as we're thinking into preparing for future pandemics. Thanks.
Thanks for the easy question. And I haven't heard that term. What was it? An equipment graveyard. So, you know, I don't have any great insights on that. I think that is, again, similar type of response to the question earlier. I think what this provides is those high-level insights, and then if there's something there to really then probe a bit further and understand what happened and why. I think other groups, and it's a shame that Grace Chi, I know she participated, it sounds like virtually yesterday, but her team at the Momentum project have been, I think, tracking that type of work in more detail. So I would probably punt and say, maybe ask that question to Grace Chi. And that's what the nuance that I was trying to also add in my comment, that I think there was perhaps a lot of excitement with a lot of these new digital tools on the one hand. On the other hand, I think they were a bit overwhelming. They weren't stitched together. They were very kind of band-aid approached. So frankly, it's not surprising that a lot of them haven't stuck. You know, if and we probably will have to do this again within our generation, I would hope that we learn from that. How? I'm perhaps not the right person to answer that question, I'm afraid, but it's a good question. Thank you.
Thanks. Other questions over there, Uni?
Would you mind showing the second to the last slide? Because I found that the results around the priority population is quite interesting.
Yeah.
Like 60 to 70% of the 17 countries are actually still vaccinating adolescents and children's group. And you're already aware of the change in the stage guidance on prioritization of the COVID-19 vaccines, and now they're moving more towards the focusing on the high-risk group, and specifically for adolescents and children group, it should be based on the country's consideration of the programmatic implication, as well as the cost effectiveness evidence. So I was wondering, even if the population hasn't changed, is there any willingness for countries to change their target groups going forward? And if there's any also willingness to do so based on economic evidence? Thank you.
Thanks for the question. I mean, and it's a very good question. Again, these are the types of questions that I think the survey findings beg, but don't answer. So in a similar way, it's certainly we could be launching very more focused surveys that probe on some of these particular questions. That point that you asked didn't come up, I think, in the more kind of open-ended questions we asked, what are the types of criteria that you're using in order to target these subpopulations? It was much higher level, which target groups are you continuing to kind of target in any meaningful way? So, yeah.
Other questions over there in the back?
Thanks for this great presentation. Anthony Ngatia from Chai. I'm not sure if you actually covered this in your survey, but it would be great if you could also just reflect on the political structures that were there pre-COVID and what the political structures were. So for example, was it run by the Ministry of Health, by the economists? I know maybe if you didn't take it, maybe it's something you can also take retrospectively to also just figure out, but if you could just pontificate and reflect from all the surveys, like how is that structure, how is the political structure changing, or if it's just the same? Thanks.
Yeah, it's not something, again, that we intentionally included in the survey, but as you say, it's something that we could kind of add on retrospectively in order to understand the extent to which, and I guess this is the way, the direction your question is going in. Do those political structures influence the response in any meaningful way in terms of how the health system is organized and the speed with which they're able to kind of ramp up? Because we saw dramatic differences in terms of the speed with which the vaccine was introduced and taken to scale across those countries. It's something we could do. I think it's a very interesting kind of question, and could be an additional layer of analysis that we add on to this. Thank you.
Maybe one more question before we wrap up. Please let Sarah. Don't fight.
That's fine. Thank you. Good morning. I'm Sarah Pallas from CDC. I was just going to ask you about the use of the survey findings, like to whom have you shared them and kind of the motivation for them? So there were several efforts at pulse surveys and others, and some also, each partner was kind of trying to source from its country offices. So WHO, what are we hearing from the countries in the regions? UNICEF, what are we hearing from the countries in the region? CDC, what are we hearing from our country offices? USAID, what are we hearing from our missions? And that's just one bilateral perspective.
Yeah.
So why did MSH undertake this? And with whom did you share the results and how were they used?
Yeah, thanks. Great question. I probably should have shared a bit more about that at the very beginning, but the first survey, as I say, was undertaken in November of 2021. We had some funding from USAID's Vardy. And so in parallel, and we fixed this in the end, but we were initially being asked to produce our own global estimates for Vardy. And we pointed out the fact that there was a much bigger group that was leading those efforts, and in time we came together and ended up producing a single set of estimates. But the main motivation at the beginning was to produce data that could be fed back into those global models, as I say, particularly around the human resources and the extent to which new human resources were being hired, and also the different delivery modalities. So it was very much to move as quickly as we could to generate high-level insights and to feed those back into the global model. We actually built off of, I think, a survey that was put together very quickly by UNICEF and WHO. I think Ulla and Natalie sent out a similar survey to 10 countries before we sent ours out. And so we collaborated with Ulla and Natalie on that, expanded the survey a little bit more, asked the team what other questions might be useful to ask as well. So that was the kind of motivation and where we started. In terms of how we've been sharing this, I think it's been fed directly, as I say, into the ongoing work that we've been doing. It's been fed back to the teams that gave the answers to us as well, so they could understand, what it looked like vis-a-vis the neighboring countries, other countries in the region and beyond. And we also have a paper that is, I think, just being accepted by vaccines. So we'll be getting it out, to a more of a research viewership as well at some point too. Thanks.
Very last question from Ula.
Yes, I was allowed to speak. So it's not really a question, it's also a comment. So first of all, with the graveyard of UCC, I think it's a really good issue. So at UNICEF, we procured a lot of the UCC, and it was extremely sort of hectic. And in the latter part of the pandemic, a new piece of equipment did come out where you could switch between temperatures. And we were trying to push that because we knew the -70 wouldn't be used so much. So it could be switched to -15, which is for polio. But I'm not sure how much came out, but I really think that's probably we talked about research priorities yesterday. I just think it'd be great to do an evaluation of what actually happened with all this, because at the height of the pandemic, there was a lot of talk about what about all this equipment, and then everybody just forgot about it. And I think also we did come to the conclusion it wasn't in the big grand scheme of things, the expense wasn't that high. It is in our global model a tiny percentage of the global overall cost, but still it was a lot of waste, I'm sure. So I would love to document that. Then secondly, it's just a comment, like we talked a lot about the integration in your slide, integration. It's kind of a buzzword, like what do we actually mean? I don't think any of us know. So that's another research question that we are trying to look into, because that vaccine is going to target totally different population than childhood immunization. So no, it can't be integrated into that. So it probably should be integrated into prenatal services for pregnant women, or HIV for HIV positive, something like that. That might be what we mean, but I don't think so perhaps your respondent didn't know it either, what you meant. I wonder, yeah.
Yeah, and so it sounds like I maybe have a final word on this. I mean, we're equally frustrated by some of the answers we got here, because as I say, you're like, well, okay, so what does that mean? Could we, and unfortunately can't quickly go back to the response and say, tell us a bit more. And in fact, when I was preparing for this on Shani's behalf, I was thinking integration, but again, it's so loosely defined. All we've got is basically a tick box. Yes, no, did you use that word? And perhaps even the question was a bit of a leading question, where respondents were kind of nudged in the direction of saying, yes, of course, we're integrating our ongoing efforts as well. So I would think, and based on some of the questions that I got, I think there's a lot of value in doing these types of rapid surveys, but they really then need to be built on, and you need to then go a step further and probe a step further on the things that matter and the insights that you generated. If you identify something interesting, then go a step further. We didn't. I hope many of you might then take this research a bit further, and we would like to ourselves as well. But thank you very much for all the questions.
Thanks so much, Damien. So next, I would like to introduce Sebastian Ilomuanya and his team, and they'll be giving a short presentation followed by a discussion on transition and immunization financing issues in the countries that they work in. A warm welcome to Sebastian.
Thanks, Laura, for the introduction. Okay, hi, everyone. And thank you for joining us in this session on Gavi transition. So Gavi is actually the Vaccine Alliance and one of the global partners, but that supports countries in their immunization program. So that means they support countries in different ways. One of such ways around co-financing their vaccines, depending on the level they are on Gavi transition. So there's a graph there that sort of shows the different stages of Gavi transition for different countries. So depending on their GNI and which we still come around to later, these countries pay at a minimum 35% of the cost of vaccines, while Gavi funds the rest. So that's one support that Gavi provides. But in addition to providing this support, Gavi also helps countries in providing funds for operations through health systems and strengthening support. And what this means that they pay for certain things like maybe outreaches, supportive supervision, and the rest. And they also provide TAs to the countries. So they pay people also to help countries in their planning, in their implementation, and all that. Then finally, which is, let me say, maybe a hidden cost that some countries are not even aware of, Gavi also ensures that countries get their vaccines at a lower cost than people, other maybe more developed countries will naturally get. So what does it mean for countries when Gavi as a donor is leaving that space and mean that countries will need to take up these costs? What even determines that countries will transition in the first place is their GNI. So once those countries meet a GNI based on the World Bank of 1,730 USD per year over the past 3 years consecutively, it means that they are now in a phase where they are supposed to gradually increase their costs or the amount they bring for vaccine for financing and even operational costs, and Gavi gradually withdraws that. So this is a sustainability plan or mechanism that ensures that when Gavi transitions, countries still continue to achieve their immunization goals and possibly even increase their immunization coverage, maintain the current vaccine offering in their immunization program, and also introduce new vaccines. That's for us and Gavi is what now defines a successful transition. But there's still that question of how countries can do this in a sustainable way, both programmatically and financially. So we went into this work using funding from BMGF and also a lot of thought partnership with Logan to try and answer some questions. So we went in asking a lot of questions. How are countries even going to do this? There's tight fiscal space. Countries have different priorities, right? And so how are they going to even make this Gavi transition work a priority? What are the biggest risk areas for countries if they are transitioning? We mentioned that Gavi provides space for TA. Gavi also gives funds for outreaches and all that. So if that they are taking away this cost, that means there are also the gaps in the management systems and possibly the capacity of the staff. How will the countries be able to do this? Then between the period of transition, well, between the period of getting into transition and actually fully transitioning, there will also be funds are available to these countries to do a lot of things. How can these countries better use these resources in an efficient way to ensure that they reach those transition goals and continue to offer the program post-transition? So to help answer some of these questions that we have, and based on the work we have been doing over the years, we have our people from the country that will be here to help describe some of the things that we've seen, at least some of the practical lessons that we've also seen over the years. Our country teams from Nigeria will be talking a lot about what happened at a national level, especially in trying to meet and continue to increase the co-financing requirements since they entered the accelerated Gavi transition phase in 2018. Our team from Kenya will be looking beyond that at the subnational level and some of the operational costs and how the countries can mobilize resources at that lower level through DFF and PBF mechanisms. Then we have our team from Laos that will also be approaching that, looking at taking an equity lens. One thing I'm looking at, if you're going to be increasing these costs, are you displacing this cost to patients or to an entrepreneur program? What does it actually mean? So I'd like to call up my colleagues to occupy these empty seats. I have Kike Lomo Lambo and Sima Onogu from Nigeria, Faith Mutuku and Victoria Wanjoy from Kenya, and Pravina Guratnam from Laos. Thank you. Okay, so we start with the our team from Nigeria to talk about the vaccine for financing at the national level. Sima, okay.
Thank you, Sebastian. Good morning, everyone. And we'll just be talking about what we've done in Nigeria post entering the accelerated transition phase in Gavi. Just a brief historical context. Since 2001, Gavi has been supporting the country, and about 71% of their support is for vaccine supply. As of 2018, just like Sebastian mentioned, we had crossed the threshold for Gavi support. So we entered the accelerated transition phase. And in response to that, the country started a 10-year transition plan. That's to see that we begin to take ownership for our immunization and primary healthcare. And as of 2019, as a financial strategy, there was the introduction of immunization financing in the service-wide vote in the budget line. And between 2019 and 2023, we have seen a 34% increase in what the government has been allocating to the service-wide vote. This we'll discuss later. But amidst all this, I mean, we have programmatic and financial challenges, one of which is a tight fiscal space, as mentioned by Sebastian. There is also the fact that we have low accountability at the EPI managers level, and then there is the bureaucratic process that leads to delay in funding. But the role CHI plays in trying to see that these challenges are mitigated has to do with our development of the strategy plan, also a vaccine financing end-to-end process plan that was developed, and supporting in the development of the medium-term expenditure framework. Just to highlight strategies that we had supported with, there are two of them. The first is the accountability framework. And this is sort of a monitoring tool that the country has. It has like 15 indicators across 4 thematic areas: health financing, financial management, governance, and then programmatic performance. And domestic financing, which is one of the key ones, is the introduction of immunization financing in the budget line. The federal government had done a commitment letter to Gavi in light of ownership, highlighting that immunization will be financed either through the service-wide vote, the first line charge, or through the basic healthcare provision fund. And we had seen as of 2019 that we had met it through the service-wide vote. We also have optimizing immunization forecast processes. This we'll discuss later. And just in summary, this is showing how we have increased our co-financing obligation over the years. The chart on the left shows what we had committed to from the year of the transition till when Gavi transitioned out of the country. So from 2019, as you can see, from 2019 down to 2029, when we expect to own our immunization programs, you see that Gavi's proportion declines while that of the country increases. And the chart on the right shows what has actually been allocated for vaccine financing in the service-wide vote through the government budget. We see as of 2019, we started at $53 million, and currently as of 2023, what we had in the budget was $150 million, showing a 34.3% increase. And how did we do this? There are 4 factors that CHI supported the country in doing, which we have coined around 4 thematic areas: tools, coordination, advocacy, and processes. So for tools, we mentioned the accountability framework, and then there's also the vaccine finance plan, which is prepared annually. This looks into where the funding for immunization program will come from. The federal government, what proportion would the government support with? How much will Gavi support with? It also considers the risk and the risk that the country will face given the tight fiscal space we have, and also mitigants that would ensure that there is no hindrances to meeting our obligation. And then there is coordination, which is very important. Coordination between the 3 critical ministries: the Ministry of Health, Ministry of Finance, and the Ministry of Budget Planning. And this was done with the establishment of a vaccine finance and accountability tax team, which CHI coordinates, has members from these 3 ministries, as well as our donors, BMGF, Gavi, and other local partners. Then there is the interagency coordinating committee chaired by the Ministry of Health that oversees our immunization program. Then we have advocacy, which everyone knows is critical. The advocacy is critical, looking at vaccine champions. We identify champions across the upper and lower chambers of the National Assembly. So these champions help us to support the defense of the budget, how much we're putting for immunization financing on the budget, and also leads our plea for including immunization financing in the first line charge. And then we had processes that needed to be optimized. If there is no budgeting of funds for immunization, then there is no release. And for us to actually budget funds, the forecast needed to be done and coincide with the budgeting cycle. So that process needed to be optimized to ensure that the forecast is concluded just in time for submission to the budget office for inclusion in the budget and then having the funds released. This is basically what we have in conclusion. We have another session tomorrow that talks in detail about how the country has been able to sustainably map a pathway for self-financing. If you want to know more about this, we can come to that session. Thank you. I'll hand over to Sebastian.
Thank you so much. Thank you. So we will take quick questions when we have gone through all the countries. So if you have questions, just pack it for now. So we'll go to the Kenya team.
Good morning. My name is Faith, and I'm from Kenya, the Kenya team. Okay, so just to provide a bit of context on Kenya specifically, the government and Gavi are the largest donors to the immunization program in Kenya. And Kenya is currently in the accelerated phase of transition and is positioned to be fully self-financing in 2023. So one of the things we are seeing is that without proper planning and domestic resource mobilization, the sustainability of the immunization program and all the gains that have been made will be at risk. Despite Kenya having a relatively high immunization coverage, there are still pockets of unimmunized and even more so under-immunized children within different subnational, different counties within the country. So Kenya is a decentralized system of government, and we face several financing and programmatic challenges when it comes to the immunization program. So some of this is the increasing co-financing requirement that the country needs to make year on year before self-financing in 2030. Because it's the subnational performance varies across the different counties, and some have different and varying capabilities to meet their financing needs and also their delivery of services. There's also a limited representation of the Gavi financing within the national budget, so that doesn't provide a full and clear picture to the country in preparation for transition. And then, so to address this, we are looking at targeted interventions at the subnational level, as it is the key to successful transition. So the national government will find it increasingly difficult to raise funds for 47 counties with varying capabilities and varying needs when it comes to the immunization program. So we are seeing that the facilities need to be equipped in the mobilization of their own resources, as they are best placed to understand their service delivery needs. So when it comes to the challenges in the delivery of services, one of the things that is leading to this is that there is inadequate financing at the subnational level for their own activities. So as the facilities are unable to create and manage their budgets and also finance their needs, so they lack autonomy to retain and allocate their finances. And yet they are the ones that have the closest relationship with the community. So they are the ones who understand the needs of the community best. So when you're looking at immunization, we are seeing it as one of the core parts of the primary healthcare. And to successfully transition, structures and processes are needed to support the financial and operational autonomy of the health facility. Because we are seeing this as a key way that could lead to increased financing availability at the health facility level that could be leveraged to fund priority interventions, such as outreaches and defaulter tracking, and just the delivery of services outside of the facility itself. So when we're looking at this, one of the ways that we are looking to do this is to have the health facilities retain their own resources and allocate them to meet their needs. So Victoria is going to be telling us a little bit about how we're doing that at the facility level.
Thank you, Faith. Morning, everyone. My name is Victoria and I work with CHAI in Kenya. So over the recent couple of months, there's been a call to action for domestic resource mobilization in Kenya because as a country, we've realized that donors are transitioning and they're transitioning out of supporting key programmatic areas in the country. One of the things that is very known right now is that Kenya has moved from being a low-income country to being a low and middle-income country. So what that means essentially is that donors are finding it difficult right now to support Kenya as a country in terms of service delivery. Now, the biggest impact has been felt in terms of the primary healthcare facilities, where donors were largely supporting the process of operation and maintenance costs. And so when you have primary healthcare facilities, which offer about 96% of immunization services, not having the requisite resources to carry out outreaches or to even buy the basic non-pharmaceutical supplies such as syringes or cotton wool, then there's a problem. And as Faith had mentioned, we still have counties with pockets of children who are zero dose and children who are also under-immunized. And so the question really is, how do we get to these children in the counties where we have almost 20% of children who are not fully immunized. And then in the same country, we have counties where we have 95%. So I'm sure you'll agree with me that there are disparities within the same country, and the children are still the same Kenyan children, right? And so in comes direct facility financing. But the thing about facility autonomy is that it only works where resources are available. So if you have no resources in the facility, then it's very difficult to allocate monies to outreaches to get to these children. And so one of the greatest pushes that we have in Kenya currently is to ensure that facilities are able to raise and retain monies at the facility level to go back and plow back into service delivery. Now, of great importance to mention is that primary healthcare facilities in the country don't charge out of pocket. So we have two key sources of income for these facilities. Number one is the counties themselves. So how the counties are set up is, and sorry, I haven't moved the slide, I just started talking, is that, so the sources of funds are two. Remember, there is no out of pocket. So we have number one, which is the counties. So counties allocate almost 30% of their total health, of the total county budget to health. Of this 30%, 70% goes to HRH. So what are you left with? 30%. As we know, curative has, for the longest time, been allocated to more resources than primary healthcare. So 25% goes to curative. Then you're left with a paltry 5% to do primary healthcare services. And so you'll agree with me that the resources are really minimal to do service delivery for outreaches or to even buy the basic commodities in primary healthcare facilities. So what we are left with is the National Health Insurance Fund. And so under this, we have capitation. And a lot of people in Kenya are not usually capitated to primary healthcare facilities, again, because of the challenges in terms of lack of services or lack of access to services in these particular facilities. And so we have what are known as the managed scheme. And these are schemes that are usually allocated resources by the parent ministry. So we have two. The first one is Linda Mama, which is the free maternity service. And the second one is Edu Afya for secondary school students. So secondary school students can access care in public facilities and private. And so how it works is that the facility would ideally offer the service and claim for reimbursement from the National Health Insurance Fund after they've offered the service at a fixed rate, depending on whether it's ANC, whether it's delivery, PNC, and for the secondary students, it would be outpatient. So moving on, what we've done as CHAI is that we realize that there's a gap because these facilities are offering services to the community, but they're not claiming for reimbursement, again, because of a myriad of challenges. Number one is that they don't have the requisite infrastructure, which would be the basic desktop, the basic scanner, the basic printer to put in a claim after they've offered the service. Number two is that there are capacity challenges in terms of the health, the human resources, so that they don't have the capacity to claim for these services. And so what we realized as CHAI is that there is a gap. So we decided to do sort of a proof of concept to go to one of the facilities in the counties and be able to understand what this looks like. And so this graph, and I don't know whether you can see the blue and the green. So in April 2022, we carried out a baseline assessment to be able to understand. So this is a dispensary in one of the counties in Kenya. The missed opportunity was about $1,300. So they were offering ANC and PNC, and this is a facility without maternity. So if it had a maternity wing, this would be more resources. So this facility has been in existence for almost 20 years and has never claimed for a single shilling from NHIF. And so with CHAI's intervention, since April 2022 to date, this facility has been able to claim approximately 14,000 USD from zero. So what does that tell you? There is an opportunity for facilities to be able to raise resources from the NHIF. But the thing is not just to raise resources. How are these facilities raising resources and allocating resources? And so the element of strategic purchasing comes in, where capacity building is required. So you can raise the resources, yes. So you have facility autonomy, you've raised the resources, but there's still a gap, because how are people, or how are the facilities allocating these resources? Are they allocating them to just operations? Are they allocating them to improving service delivery? And so one of the key things for CHAI is to ensure that we are building capacity of these health workers to be able to allocate resources to the relevant priority areas within the community. So if it's, and it's not just in relation to immunization services, but also to improve primary healthcare outcomes. So if it's outreaches, the facility would allocate resources to outreaches and go and also conduct outreaches for other disease areas. And so I think that brings me to the end of my presentation, but basically in a nutshell, that's what we're doing as CHAI Kenya. Thank you.
Thank you, everyone. Good morning. I'm Pravina from Chai Lao, and just want to complement and continue from what my colleagues in Nigeria and Kenya have been describing, to talk a little bit about Lao and our sort of journey on the Gavi transition path. So Lao is currently due to transition fully from Gavi support at the end of 2025. And similar to what we've heard throughout these sessions at the Immunization Economics SIG and also from my colleagues, there are many very quite intractable challenges that the country is facing. I want to talk a little bit about those and about some of the strategies that we've been trying to deploy to support the government. Okay, sorry. Some of the strategies we've been deploying and supporting the government and working with other partners to deploy to work towards an effective and sustainable EPI program post-Gavi transition in Laos. But I want to focus particularly on what the implications are and what these mean for equity, and in particular, how do we reach and sustain reach of children that are currently missing out on immunization, including zero-dose children in this context, and do so in a way that can be not just a one-off intervention, but sustained through and post-Gavi transition. So similar to many countries in the room and around the world, there are very serious fiscal space constraints in Laos. More so after the COVID pandemic, but also ongoing issues around debt servicing, government expenditure on health, stagnating at around 6% of total government expenditure. So the pie is not getting any bigger, and how within this do we make sure that there's ongoing funding for immunization, while also recognizing that there are multiple other priorities. And a very key part of, I think, the story in Laos and the sort of process that we've worked through with the government is really to articulate that in the context of Gavi transition, it doesn't necessarily mean that the program is going to look exactly the same as it does today with significant levels of external support. There needs to be consideration of what's appropriate in the Lao context, the overall sort of government vision around health sector reforms, health financing, integration of services, and also, feasibility and sustainability in terms of figuring out what will the program look like. And so in order to do this, and particularly in the financing area, situating the discussion around vaccines and procurement of vaccines, but also operational costs very firmly in the context of overall health, the overall health financing situation, health financing reforms, and in particular things like ensuring further strengthening of the National Health Insurance Scheme, improving revenue collection, reimbursements, administration, etc. But also looking, specifically within the vaccines program, obviously we know that there are, specific things that can be done, measures that can be taken to improve savings, cost effectiveness. Some of the recent sort of measures are obviously, following clinical evidence and being able to move from HPV 2-dose to 1-dose, for example, will have a huge impact on costs, but in itself is not going to be probably sufficient to really solve the whole question of financial sustainability. So additional measures are needed. And also in light of the integration agenda and primary healthcare, also recognizing that there are efficiencies that can be achieved through efficiencies and increases in quality of care as well that can be achieved through further integrating EPI with other MCH services. But this shouldn't be done with the assumption that there's no cost associated, that you can do twice as much for half as much. It really requires more rigorous thought and costing and trial and error and implementation to figure out what actually are the savings from this, and where might there be additional operational costs, but also where does there need to be more attempts to actually have cost sharing between programs, so that it actually is kind of helping pool resources and allocate them more efficiently. And this is also important from an equity point of view, because I think we see in Laos, as I'm sure that we do in other countries, that the communities and the children who are missing out on immunization services are also likely to be missing other services. So taking an integrated approach to service provision is a way to address those equity barriers, not just for immunization, but for other services as well. When we come to looking at how services are actually delivered, there's still a very high dependency on donors particularly to fund service provision through outreach. So some analysis that was done in 2021, for example, showed that approximately 21% of the coverage for Penta-3 could be attributed to donor-funded outreach. So if that donor funding had not been there, the Penta-3 coverage would have been just 65%, and approximately 32,000 children would have missed out on Penta-3. So though you can look at the Lao coverage figures, the reported figures, and think Lao's doing okay, and they are in a lot of ways. The reality is that once that donor funding, and it's not just Gavi, it's other donors as well, once that disappears, there are real big unanswered questions about how the service provision is going to be funded, irrespective of whether or not the vaccines are able to be procured and delivered to the country. So again, a very big question, and obviously the reliance on outreach is very very acute for communities, families, children who do not live close to health facilities, so they don't they're not able to easily access the health facility. In Laos, again, I think, as I'm sure in other countries, distance from the health facility is also correlated with other factors such as lower wealth in the household, ethnicity, being from an ethnic minority, factors such as that. So a number of kind of factors and things which influence equity sort of congregating together, and so really important and critical to ensure that people who are not able to come to the facility are able to still access services, and that can still be funded, and that there isn't an assumption made. It's obviously can see that there are a number of savings potentially from sort of saying we're going to increasingly deliver services just through the facility, not through outreach, and certainly that can be a solution for some part of the population, but has to be done in a way that it's not just not just assuming that the patient can not just, transferring the cost in terms of time and financial resources to come to the facility, not just transferring that to the patient without thinking about what the equity implications might be. And finally, I think a real challenge has been really, over this long period of Gavi support for not just the financing, but for the programmatic capacity building. It's been a real, a lot of work has happened, but it's been a real challenge to really measure and define where have these capacity building efforts been successful, and where are the real, where are the real outcomes, what has been effective. We do continue to see both at the national and subnational level that there is a lot of dependence still on partners for some key critical competencies. And often very difficult, with interventions to really clearly measure and see, okay, is this something that actually had an impact in terms of we can measure even down to the health center level, measure that, we went in and we did this training or this intervention, and then we can clearly see that, there was an increase in immunization coverage, which we can do now with the routine data that we have, and we want to sort of increasingly start to do, particularly to ensure with, some of the remaining funding that will be available from Gavi for equity interventions, that they're being deployed in a way where we can really see as much as possible that there's a direct impact on zero dose and missed children numbers. And so then can also, make a case for sustaining those interventions. So just quickly, we've, just going through here, tried to support at every aspect of the process from planning. So ensuring that there are clear equity targets in the national government policies and strategies. So one example of that is saying that all districts, so, saying irrespective of where you live, basically, the target is the same, that you need to, achieve 95% coverage of Penta and MR. And, so hopefully, having that accountability to ensure that there is equity in coverage and not just, at the national level, but at the subnational level as well. Costing and budgeting and combining that with, firstly, understanding what is the actual need, including what are the needs in areas where there might be additional disadvantage and where there potentially might be higher costs associated with reaching populations, whether that's through more outreach, through overnight visits, through different sort of communication channels or styles to reach ethnic minorities, for example, who don't speak Lao, who don't speak the majority language, and then combining that information with resource mapping to understand where are the resources going at the moment and where are actually the gaps according to need and deploying those accordingly. Also implementing and integrating, for example, supply chain visibility, information management, stock management systems, distribution overall, because again, in terms of last mile delivery, for example, the kids that are missing out on vaccination are likely to be missing out on other commodities as well. So trying to address those issues holistically as well. And finally, evaluating, having a sort of continuous cycle of evaluation and really, when we're spending resources on something, not just looking at whether the money has been spent or not, but seeing can we see real outcomes from this, and how can we ensure that money is continuing to be targeted towards interventions in areas where it can have the most impact. So I'll stop there. Thank you.
Thank you so much, Tim. So we'll take questions now from the audience. Okay. So maybe first two, then.
Thanks very much all for the very good presentations. My question is to Kenya, but motivated by the Lao scenario, because I know you're one team. First, I think the problem statements for Kenya are really very nice, and they present the reality. I'm also Kenyan. I would want to understand, I know you're also doing an FPP process, just to understand some of the opportunities you've taken through the FPP to try and address those problems. Of course, I like the work Victoria has shared around the downstream work, but for the time that we have an opportunity through Gavi support to support us transition, learning, for instance, from what these other countries are doing, what opportunities have we taken through the FPP, the full portfolio planning to address the issues. And then another issue raised as part of the bottlenecks is the challenge around the visibility of the immunization budget. And I know it's a key problem for most of the countries that have adopted program-based budgeting. So I would like to get reflections, not necessarily from Kenya, but maybe any other countries in the room, Nigeria, for instance, which I think is developed also in a similar way, on how that may be managed, especially given that we would want subnational governments to prioritize immunization better. Thanks, over to you.
Thank you very much. I think it was three very interesting presentations, and thanks for sharing your experiences. So I have a question for Kenya, also one for Lao. Kenya, I was interested to see you're working on ring fencing funds for health. I was wondering a bit about what your experiences are and what your advice is also for how to do this properly. Because I think the research that is published on ring fencing funds is largely showing it's unsuccessful. So I think how maybe you can talk a bit about how you plan to make this or how it's working and what you did to make it work, etc. And Lao, I had 2 points actually which really stood out to me. One was on the portfolio optimization work you were doing. Maybe you can talk a bit more about the decision-making process and the potential savings or the savings that you identified through that, if it was worth going through that for this, like what the impact was. And the second point was on the integration of data management system, if I understood correctly, for the stock management, which I thought was interesting also given how verticalized the program is. Maybe you can talk about how you did that, how you made it successfully and the impact of it a bit more. Thank you.
Okay. So I'll start with the responses to the first two questions. So when it comes to the full portfolio planning for that Kenya is undertaking, we are due to submit our portfolio plan later this month in July. And one of the ways that we are looking to optimize this, given that it is the last HSS cycle for Kenya, probably, one of the things we are doing is focusing specifically on health system strengthening at the subnational level. So not having blanket interventions for the entire country, but specifically looking at the counties that require it the most. So looking at the counties specifically that have high numbers of zero-dose children and also high numbers of unimmunized. So when you look at the fully immunized children, there are counties that have higher, like even up to 50%. So those are the interventions are focused on those ones. So some of the interventions that we are looking at include things such as screening at the health facility to reduce the number of missed opportunities for vaccination when the caregivers bring the children to the health facility. And we are also, in terms of now reflecting on the program-based financing, one of the ways we are looking to ensure that the country has full visibility of the immunization cost is ensuring that these costings are included in strategic documents at the national level, so such as our MTEF and our health strategic plan. So ensuring that these costs are fully reflected there. So working with the National Vaccines and Immunization Program to ensure that the costing for the immunization program is clear, and also getting understanding better the funding flows is also part of the process that is informing this. And we are also working together with Gavi to ensure that on their side that they are interacting more with directly with the Treasury and not just the vaccines and immunization, the technical partners in the vaccination space.
Okay, so I'll respond to the question of how Kenya has managed to successfully do the ring fencing of funds. So the devolved system of governance in Kenya is such that the 47 counties have, they're semi-autonomous, so to speak. So out of the 47 counties, we have 21 counties that have passed legislation on ring fencing of funds. And so when we talk about the element of domestic resource mobilization, especially linked to NHIF, it will only work in counties where there's facility autonomy. Because how it works in the other counties without the autonomy is monies will be raised at the facility, but they'll be pooled into one central account. And health monies will be mixed up with trade monies, will be mixed up with roads monies. And what happens is that allocation to health, plowing back to health will be a problem. And so ring fencing of funds, especially where there's goodwill from the governors, it has worked, it has been proved to work. But in the other counties where there's no goodwill, it's a challenge. And so I would say that the key thing for ring fencing of health funds to work is that there needs to be goodwill from the governors. And also there's now a push from the Ministry of Health and the national government to ensure that counties are ring fencing funds related to health, such that there's plowback, especially to the primary healthcare facility level.
Thank you for the questions on Laos. So firstly, on the vaccine portfolio optimization, so would say that so at the moment in the current context where there is still Gavi funding available, and particularly in relation to decisions around PCV and HPV, I think it's been relatively straightforward to demonstrate, obviously, that there are savings, and easy to, I think, convince the government that this is the important way to go for now. But I think the longer term sort of question really is that, at the moment, the government, the National Immunization Technical Advisory Group, I mean, they've really been in a situation where they're making decisions in the context of there is Gavi, there's external funding for this. Potentially the decision choices, the choice set is different when it's purely external financing. And I think that's where we are also trying to, both, immunization specific, but within the broader health sector, support evidence-based decision-making that's about understanding the costs and benefits and being able to look at that across system-wide. So I think we hear a little bit, that people will say, oh, PCV is too expensive, so we'll just drop that, post-transition, which is a reflection not being able, I think, to not having the information to really understand that, yes, some things are more expensive, but some things are also more valuable. And how do we support that decision-making process? Again, not just looking at vaccines. So obviously that's really critical and will become increasingly critical as we come closer to Gavi transition, but needs to also be within the context of the whole health sector, where there are a number of competing priorities and many competing needs and targets and things like that. Secondly, on the supply chain question, so in Laos, CHI specifically with the government has been working over the last 7 or 8 years to implement an integrated supply chain system. And that started, 7 or 8 years ago, there were, separate monitoring systems for all the different programs, HIV, TB, vaccines, family planning, everything. So slowly bringing that together into an integrated system and sort of recognizing that is what, I think, led by the government, that's what makes sense. Most of the commodities are managed, by the same entities at the national and subnational level. And it was really, but it's really only been in the last 3 years that vaccines has come on board. And, I think it was a recognition that there had been attempts to sort of implement vertical systems around improving stock visibility, distribution, etc., that really hadn't yielded the effects that people wanted. So I guess there was an opening in terms of saying, okay, we already have this system that's open, it's operating, it's working from the central down to the district level. To incorporate, so easy to incorporate vaccines, and then also looking at other aspects of it, such as distribution. Also seeing that distribution wasn't, it was happening in a very ad hoc way at the subnational level, and it was a common problem across all the programs. So then, a process of, bringing people together and thinking, okay, how can we sort of work together to systematize this, pool resources? I mean, it's very, very modest resources, but still obviously in a constrained environment, a lot to ensure that distribution happens regularly from the subnational down to the health facility level, and being able to feed back the data and show that this is this seems to be working. It's worth continuing with. Yeah. So I think, in brief, I mean, having a system that was already in place and clearly seemed to be working well for other programs was, I think, important for bringing the vaccines program into it.
Yeah. Okay, great. Thank you for the beautiful presentation. My name is Waba One. I'm from Botswana, UNICEF. So for Botswana, we don't qualify for Gavi funding. So I'm sitting here and wondering, how does it practically work in countries where there are certain vaccines that are funded for and there are certain vaccines that are not funded for? One. And then the second thing is Botswana is quite centralized in procurement. So I'm hearing for other countries where it's a decentralized form of procurement, countries do procure for themselves. Do you think, is that the best way to go in terms of vaccine procurement? One, how do we then also take advantage of pooled procurement in terms of when maybe countries are buying for, procuring for vaccines? Yeah, so do you think decentralization or centralization works best for vaccine procurement?
Yes, I wanted to ask a question about sort of budget, I guess credibility here, which is the co-financing of Gavi vaccines. The original intent, I'm sorry, was to put countries on a trajectory toward sustainable financing with a vision that eventually countries would have processes in place, the budget would be forward-looking, the co-financing requirements would be integrated into that, into an MTEP, et cetera. But we know from experience that countries are usually every year scrambling to find a way to fill those gaps and to meet their requirements. Based on all of the work that the teams have done in these three countries, what is your assessment of how well integrated, say, co-financing of Gavi supported vaccines, but also traditional vaccines are in the budgets?
Thanks. Would the panel like to take those two questions?
Okay, so I'll just try to answer the question that was raised by the lady from Botswana. So I think just to be clear that the procurement of vaccines in Kenya, although it is a decentralized system of government, is still pooled. So the procurement of vaccines happens at the national level with the country, the government, paying for what we call the traditional vaccines, and then at the same time also procuring the Gavi co-financed vaccines. So it happens at the same time, yes, at the national level. So it's that the service delivery is what is decentralized, and then the counties also have responsibilities around the financing for other commodities. So yeah.
Thank you. Maybe I'll just touch on your question too, before I also go to your question. So, I mean, personally, we don't think there is one best way to get things done practically at the country level. Oftentimes, it's easy to, make decisions, but practically, sometimes it's just not applicable. Nigeria, for example, has certain policies that perhaps enhances the immunization system. For example, the procurement of vaccines is the sole responsibility of the federal government, while the operational costs of implementing service delivery is the responsibility of the subnational government. Now, that kind of makes it a little bit easy. However, as you rightly also allude to, the federal government also struggles, and sometimes it struggles so bad that the state government also has to provide some support. And that's the conversation we're currently having in Nigeria too. And so we're discussing how the subnational level should contribute of some sort to vaccines financing. And now that doesn't typically require each subnational level bringing their own resources. It basically requires commitments from them to say, pull from our allocations at the national level and use this to procure vaccines. I wouldn't say there's a perfect way to procure vaccines. However, as we all know, with simple rules of procurement, there's power in volume. And, it would help your country negotiate better if, you're procuring your vaccines as a pool. And that's kind of what we're also doing in Nigeria. With the volumes we have, we are constantly negotiating and driving down costs for vaccines procurement. integrating the cost into the national budget, I would say, as difficult as it was, Nigeria could be said to be a success story. Think about a child who has always lived with its parents, and in 2019, you basically get a call and say it's time to go to boarding school. That's kind of what happened with Nigeria. They had never financed no vaccines by themselves. Gavi had been, the parent who's always shielded the country. And here we are having to start to finance. I would say for Nigeria, for example, the cost of vaccines procurement has been 100% integrated into the government's MTEF system. But I won't say that came easy. Practically, CHI had to support the government with the basics, and the basics really entailed understanding the process. Part of what we found was the health folks, the health stakeholders had no clue what it meant to include a line item into the national budget. The non-traditional health players, the Ministry of Finance, the Ministry of Budget and Planning, had no clue what it entailed to actually ensure people are getting vaccinated. Half the time they had no clue Gavi had been funding it. So part of what we had to do to try to drive this process, like my colleague Sima had mentioned, was strong advocacy, life save, social economic benefits. What needs to be done? What does this really mean? 8 million children born annually. UNICEF says 70% of those are living below international poverty line. How much people will be at risk if we don't include this line item in the budget? And so part of what CHI had to do was actually mapping out what are the different processes to include in the budget. What is the easiest? What can we do in very short time? What is achievable and what is sustainable? So those are part of the things that went into play into understanding this. And, Sima presents it so nicely, but we've had scenarios where in the first year this was included in the budget, the legislators took it out when the budget went to defense. What do you mean we should fund a 25% wastage rate for XYZ vaccines? Take it out. We have no money and you're talking about wastages. Why should we have wastages? These are the practical things that the non-health stakeholders don't understand. And so, the health stakeholders had to go back to the legislative government to say, hey, this is what wastage means. And this is how we calculated wastages. And what you find is, as the years go by, the legislators are now your advocates. They are now saying, no, we said this last year, wastage is actually required because you need to XYZ in there. I wouldn't say it's been an easy journey. Nigeria has met its co-financing obligation to Gavi in the last 4 years. And for the first time this year, there's a struggle, but the country still prioritizes it. The country is at a point where it says, all right, if MTEF is going to be slow because we have a new government, we're going to fund it through our World Bank Impact Fund, and we're going to replace that fund when the national budget is signed. But what I would say, to maybe other countries trying to finance their programs, whether of course it's a transition or it's just the country trying to take ownership, the first lesson for us is there was simply no clear understanding between what the health stakeholders needed to do and what the non-traditional health stakeholders understood as needed to happen. We literally had to design a living process map, which says a request must go from this office within this ministry to that office within that ministry, and this process takes 4 weeks. A request must go from this person in this ministry to that person in this agency, and that takes 2 weeks. A bottleneck potentially can be in this area because this could take up to 8 weeks, sometimes as little as 2 weeks, but you got to plan for at least 8 weeks. So we have this process map that all the stakeholders, health, non-health, has. It's living. Everyone can see it. It means if your desk is delaying, you are causing a ripple effect, in the funds release process and invariably vaccines procurement process and invariably availability of vaccines, of course, for the 8 million children born in Nigeria annually.
Thanks. I think we have one last question, and then I'm afraid we're going to have to wrap up.
Oh yeah. My name is Unalena from Botswana. Like my colleague have actually said, in Botswana, we actually, health financing is actually done by the government, fully by the government, and the community is not contributing towards the public service. They receive free services. And it's very interesting that post-COVID, we realized the need to actually think about sustainable financing. And I like the story for Kenya on national health insurance. But my worry, maybe my questions or my interest is around the way counties have been expected to actually collect funds for themselves from national health insurance, whether it doesn't bring about a gap. I mean, I believe that the different counties, they're able to collect a certain amount depending on the capabilities of the population around that area or on that. So I want to know how you manage issues of disparities, or how is the government actually augmenting the different counties, since I believe they perform at the same, at different levels. I mean, even their capabilities or the targets they could be reaching, it might be different depending on the county. And I believe that even issues of equity comes into play there. You wonder if every county depend on the amount of revenue they're actually able to raise for themselves. How do the government balance out, or what is the role of the Ministry of Health in that case? And then the other question that I'm also wondering is, have you done any comparative study to see where the counties which are doing well in terms of being able to collect funds from the national health insurance, to see whether we can tap on their success story and extend that to other counties? Thank you.
Okay. Thanks. So responses to these questions and then final remarks from the panelists. Well,
Okay.
thanks.
So I'll respond to your question, and thank you for your questions. So the health system in Kenya is fully devolved. Service delivery is done at the counties. The national government Ministry of Health is policy and standards. So when I say that monies are being raised from NHIF, it doesn't mean that the county doesn't have the mandate of providing resources to health. Actually, the monies that are ring-fenced for health, this is monies that are raised from the facility. So out of pocket for the secondary level facilities, and for the primary healthcare facilities, this is monies from NHIF mainly. But it doesn't take away the fact that the county still has the mandate to provide resources to these facilities. The only issue is that counties are not allocating sufficient resources. So the monies from NHIF are supposed to supplement monies from the county, not to, actually to complement, not to supplement. So it's not supposed to be that counties are not giving the money, and so now we're just going to use NHIF as a source of funds. Remember that the monies that come down to the county come from the national government with what is known as the equitable share. So equitable share is distributed across counties based on a formula that is agreed upon. So it can be based on the population size, it can be based on the size of the county. So this differs across the various counties in Kenya. So you could have a Nairobi county, which is a very big county, but you could also have a county in an ASAL region like a Mandera or a Marsabit. And so the allocation to these counties will be different. But when we say ring fencing health funds, these are monies that are raised from the facility, but it doesn't take away the fact that the responsibility of health still remains the mandate of the county. Now, to your question in terms of lessons learned from best performing counties, yes, we've done that. What we've shown is one of the bigger counties where they have allocated resources to be able to support these facilities to actually do the claiming. But in another county, you will find that their priority is not to raise these monies. So they have not allocated resources to infrastructure. So they are still depending on donors to do that for them. And so a lot of the partners that we have in Kenya have said we cannot be able to purchase desktops and scanners and printers for this process. So if the county can be able to allocate resources to buy the infrastructure, then what we do as CHAI is we come in and we train the staff. So we don't buy the infrastructure. So those are some of the lessons that we are learning. So of course, they are best performing counties, and there are those counties which are still at the very bottom in terms of the claims that they make to NHIF.
Thank you very much, everyone, for the questions. I think to wrap this session up, can say that countries are just like that most countries are going to be transitioning, whether from Gavi or other donors. There are challenges to this, which will be countries specific, and also how these countries will address these issues will also be country specific. But there are some basic things that need to be there that requires a lot of planning, a lot of coordination, especially across both health players and non-health health players, and also a lot of advocacy. So transition is possible. It can be sustainable, but a lot of mechanisms need to be put in place. Thank you very much.